Good afternoon or good evening to everybody who is viewing this Aspire webinar, which is on freeze-all for all undergoing ART. So we know that freeze-all strategy involves cryopreservation of all embryos for transfer in a subsequent cycle, which either could be an unstimulated cycle, it could be a natural cycle or an HRT cycle. And this is basically to reduce the incidence of ovarian hyperstimulation syndrome, and probably it's a must in patients who are undergoing fertility preservation. But there are reports which have come in which says that freeze for all will probably increase the pregnancy rates, as the endometrium will not have the negative effects of the control ovarian hyperstimulation. But is it true? I don't, as far as I go, I do not do freeze for all. But let's hear both our participants, and probably then we would come to a conclusion. So we would have both of them speaking for 15 minutes, followed by 5 minutes of rebuttal by each of them. And then we would have a conclusion, and we'll also have the pre-poll as well as the post-poll before and after the debate. I also thank Organon for sponsoring this webinar. And probably we go with the first speaker. So we have Jason Francic, who is a lead physician and lab director of embryology and andrology at the Malton office, New Jersey. He is also affiliated to Thompson Jefferson University, Sydney, Kimmel Medical College, Philadelphia, Pennsylvania. And he was previously at IVI Rama America, where he was a chief medical officer. He was also working at the Rutgers Robert Wood Johnson Medical School, Liberty Comet Surgical Center at Malton, as well as Cooper Medical School of Rowan University, all in New Jersey. He has several papers published to his credit, and also has presented several oral presentations and posters, and he has received several honors and awards during his career. So he would speak for the motion, and over to you, Dr. Jason.
Thank you very much, Dr. Patel. I appreciate the very kind introduction. And I see that I have my first participant that I must convince to freeze all. So I will share my screen here, and we will get ourselves started. So again, it's a very great honor to be here today to debate this very important topic of freezing all embryos and all undergoing ART. And I will be arguing on the pro side. I want to thank the organizers of the event for inviting me to speak today. Again, a great honor. So since the birth of the first IVF baby, Louise Brown, it goes without saying that millions have been able to achieve parenthood with the help of assisted reproductive technology. The developments in the field of ART over the last 40 years have been exceedingly fast-paced. The way that we practice modern ART has very few similarities in the clinical and laboratory protocols that were first used. For example, there's been the introduction of ovarian stimulation, the prevention of LH surge, intracytoplasmic sperm injection, the use of recombinant gonadotropins and GnRH antagonists. In the laboratory, the use of extended culture to the blast stage, and these are just some of the advancements that have transformed the way that we practice. These advancements have all been primarily driven by the desire to make ART more efficacious, safer, and friendlier and more accessible for patients. One of the major breakthroughs in technology has been embryo cryopreservation. And with this, the introduction of vitrification. Now, vitrification has been shown to present clear advantages to traditional slow freezing, with many systematic reviews and meta-analyses all convincingly showing superior survival and live birth rates. There are several common indications for freeze-all, and this includes clinical indications for pre-implantation genetic testing for aneuploidy, monogenic diseases, or structural rearrangements, fertility preservation, or the risk of OHSS in the current stimulation. I don't really think that I need to spend a lot of time debating these, and so I won't. These are pretty standard reasons for freeze-all. However, there are some other factors that I will be discussing. The first is having a quote unquote OHSS free clinic. This can allow for more aggressive stimulation, which could result in fewer total fresh IVF cycles in order to build the entire family. There has been a push in our field to have a single stimulation cycle build and have success with not only the first pregnancy, but building the entire family with ultimately frozen embryo transfers down the road. We'll present data on improved neonatal outcomes. We'll discuss avoiding deleterious effects of the superphysiologic steroids on the endometrium. We'll talk about premature progesterone elevations and the literature that surrounds that. But we'll also focus on embryo growth in the laboratory and kind of discuss embryo and endometrial synchrony. We'll briefly discuss at the end the ability for non-day 3 starts and the use of medroxyprogesterone acetate as an antagonist, and then we'll talk about scheduling for patients in clinics. In terms of OHSS risks, this meta-analysis from 2019 has suggested that the risk of moderate or severe OHSS is significantly lower when a freeze-all policy is adopted compared to conventional fresh transfer in both normal responders and in high responders. In the normal responders, there were 2 studies of almost 3,000 patients, and the high responders, 1 study of over 1,500 patients. There has been a reduced risk of OHSS with freeze-all strategy confirmed in a recent Cochrane analysis in 2021, which had included several additional studies. And so this could allow for not only reduction of OHSS, but again, perhaps more aggressive stimulation, not having to worry about late onset OHSS after a fresh transfer. We'll talk about some of the obstetric and neonatal risks. This review by Ventus and Human Reproduction in 2022 summarize several studies from Maheshwari from 2018 and 2012, and it looked at favoring fresh FET on the right and favoring frozen ET on the left. And I'll just highlight the ones that favor the fresh ET. Many of these surround being large for gestational age or high birth weights and hypertensive diseases of pregnancy. On the other side, with the fresh ET or with the frozen ET, you have lower risks of low birth weight, placental issues, abruptio and previa, lower risk of preterm birth, and lower risk of small for gestational age. One of the things to touch base about in regards to the items that are favoring the fresh embryo transfer is that perhaps it matters how you do the frozen embryo transfer. And there's been a lot of looking at whether or not a natural versus an artificial frozen embryo transfer can mitigate some of these risks. In this meta-analysis in 2021, they looked at the hypertensive diseases of pregnancy, and a natural cycle frozen embryo transfer showed lower risk of hypertensive diseases, preeclampsia, and a trend towards a decrease in gestational hypertension. In addition, it also showed a trend for a decreased risk of large for gestational age and macrosomia. So for the things that had favored the fresh transfer, perhaps doing a natural cycle frozen embryo transfer mitigates those risks. Frozen blast transfer also reduces the incidence of ectopic pregnancy compared to fresh blast transfer in this meta-analysis. We can see that there has been a significant reduction in ectopic pregnancy. We will transition a little bit in the last moments that I have here to discuss some of the embryo and endometrial receptivity. This review by Leslie and Young in Fertility and Sterility in 2019 stated that by definition, endometrial receptivity is that period of endometrial maturation during which the trophectoderm of the blastocyst can attach to the endometrial epithelial cells and subsequently proceed to invade the endometrial stroma and vasculature. Receptivity does exist along a physiologic spectrum. If you have mild implantation aberration, you could have placental diseases, which could result in hypertensive diseases of pregnancy, growth restriction, etc. If you have deficient implantation, this can result in pregnancy loss, and complete implantation failure results in infertility. I want to revisit this concept of embryo and endometrial receptivity and synchrony. In a natural cycle, you have the onset of the LH surge, followed by ovulation and an orderly rise of progesterone. This rise of progesterone is the signal to the endometrium, which then develops along a timeline to the point that it is ready to accept the embryo or the endometrial window of receptivity or implantation. The egg ovulates, egg and sperm meet in the fallopian tube, and the embryo develops until it arrives in the endometrium ready to implant. So you need both. In a stimulated cycle during IVF, we see that with HCG administration or even with GnRH administration with multiple follicles, the progesterone rise is more rapid. And that can shift the endometrial window of receptivity forward by as much as perhaps 16 or 18 hours. The embryonic window of receptivity stays the same, or as we will see, may be even shifted to the right because embryos can grow more slowly in the laboratory, particularly in older patients. So, to revisit this, in a stimulated cycle, you have the progesterone rise of 16 hours and you have the embryos developing. Embryos can develop quickly, as in the bottom slide with a hatching blastocyst, more slowly, as in the middle, with a expanding blastocyst, or still more slowly at the morula stage. And these embryos implant at different points in their window. You also have the window of endometrial receptivity shifted backwards or forwards, and you can see that you may have decreases in pregnancy rates simply because of embryo and endometrial dyssynchrony and not because of any fault of the embryo or the endometrium itself. The concept of freezing for premature progesterone rise is not new. This has been around for some time. This meta-analysis from 2013 had looked at progesterone thresholds above 0.8 nanograms per milliliter being associated with reductions in pregnancy, and higher progesterone levels were associated with still greater reductions in pregnancy. Hill et al. Looked at this a little bit more recently in 2018, and they looked at this as a cost-effective or number needed to treat analysis. And they found that a threshold of 1.5 nanograms per milliliter for cryol was both cost-effective and had a low number needed to treat. However, there were statistically significant differences in pregnancy rates with progesterone levels elevations as low as 0.4 nanograms per milliliter. And that's one of the issues with the literature surrounding the premature progesterone rise is that levels vary, and even very, very low levels have statistically significant differences in pregnancy outcomes. To go on the flip side of things with the embryo, this is something that is not looked as much at by clinicians because it's happening in the embryology laboratory. But we do know that older patients have slower growing embryos in the laboratory. This was originally presented by Foreman et al. In 2013, and Bruce Shapiro had also looked at this. And he looked at this with a combination of the two. So as age increased, the premature progesterone rise also increased, and they also had slower growing embryos. And that resulted in overall asynchrony of the endometrium and the embryos as age increased. Healy and Hill had also looked at this using a premature progesterone rise of 1.5 nanograms per milliliter, and they looked at day 5 versus day 6 embryos. This ultimately stated that a premature rise and slow growing embryos compounded for resulting in asynchrony and lower pregnancy outcomes. So we had looked at this and we wanted to really focus in on just the embryos. The endometrium can be very difficult to measure and control for, and we did so by having no patients have a progesterone rise above zero point 0.4 nanograms per milliliter. This study was made possible by a shift in the laboratory that was abrupt. The PGT platform was being validated, and we went from the afternoon fresh day 5 transfers to the morning of day 6 fresh transfers, and then also had frozen transfers. You can assess embryonic development in the laboratory, and we found that morula and B1 embryos, when graded on day 5 versus B2 to B6 embryos, had different sustained implantation rates. So we looked at the difference between fresh day 5, fresh day 6, and frozen embryo transfers. For fresh day 5 embryo transfers, not surprisingly, by definition of the study almost, those embryos graded as morula B1 on day 5 versus B2 to B6 had lower sustained implantation rates. However, when we looked at fresh day 6 transfers, now remember, these fresh day 6 embryos were at the B2 to B6 stage when they were transferred. They had been graded as morula B1 versus B2 to B6 on day 5, but on day 6, the early embryos had caught up. Also, embryos that arrested in culture overnight were not transferred. So we saw an improvement, yet a statistically significantly lower chance when a fresh embryo transfer was formed when these embryos were early. We then looked at frozen synchronous cycles, where embryos were all frozen at the point that they were ready to go back into the uterus, and we did not see a difference in outcomes. So doing frozen embryo transfers allows for a restoration of this embryo and endometrial synchrony issue and improvement in pregnancy outcomes. In the last couple of seconds here, I just did want to briefly talk about the use of Provera as an antagonist. This can result in obviously fewer injections. It could be more patient friendly, a decreased cost of medication. There have been a number of studies which have shown equivalence between antagonist and Provera as a GnRH antagonist. And it could also simplify ovarian stimulation, where you have a single injection of a long-acting recombinant FSH, and you decrease the amount of monitoring visits that the patient requires by just giving them Provera throughout the cycle. So in terms of our SWOT analysis, strengths would be an OHSS-free clinic, which would allow for more aggressive stimulation. There's higher implantation and live birth rates, as we've seen, lower miscarriage rate, lower ectopic rate, and overall improved neonatal outcomes, particularly when a natural cycle frozen embryo transfer is utilized. In terms of weaknesses, there is not very good data for improved outcomes in normal responders, although the patients that we presented in several of the studies were normal responders. Rare cases of OHSS with GnRH agonist trigger, and a dependency on the laboratory cryosurvival rates. For opportunities, there are more oocytes per stimulation, there's schedule flexibility, and you can allow for non-day 3 starts or random starts, and Provera as an antagonist. In terms of some of the threats, particularly in the United States at any rate, where we rely on insurance providers in some instances, they may not allow for this. There are some incremental costs of frozen transfer, although you have to take into account the costs associated with OHSS, ectopic pregnancy, and neonatal outcomes with fresh transfer. There has to be patient and provider acceptance, and there is a change to the workflow in clinical practice. I appreciate everybody taking time to be here this morning and to listen to me. And I am looking forward to my colleague's rebuttal and his discussion.
Thank you, Jason, for that good insight. Uh, I think we forgot to do the poll, so we'll have it now. And after that, we would have the next talk. You can just stop sharing, Daniel, so that we'll have the poll and then we'll have your talk.
All right. Okay, thank you so much,
Yeah.
Dr. Fernandez. So now, after we...
Kumtyate, they're going to have the poll. 1 minute.
Okay, all right,
Just
sure,
have the poll.
sure.
Oh goodness, this is like having grading immediately after your presentation. If I can't win the
I
poll
think
after I gave the talk, then Dan, you don't have to even give yours.
I think they've forgotten. Chichi, are you doing it?
Yeah, should I stop it now? Or
Yeah.
okay, sure. Okay.
We had kind of interim poll. Is the poll ongoing? Because I don't see the poll.
You still can see. I just closed
I don't see the poll.
This is the result for the polling. Can you see it now?
Okay, so right now, for the interim poll, I would say that we get 55% yes for freeze all for or undergoing ART, and 45%, the difference is not that much at the moment. Okay, so let's now move to Dr. Langsberg for his motion against freeze all for all undergoing ART. Let me briefly introduce Dr. Lansberg. He's an obstetrician and gynecologist specializing in reproductive endocrinology. He earned his medical degree with honors from Ben Gurion University in Israel and had completed his certification in ART at Sheba Medical Centers. He currently is a clinical director of Melbourne IVF and medical sub-lead director for public fertility service at the Royal Women's Hospital, and also he holds a senior lecturer's role at the University of Melbourne. Well, please, Dr. Langsberg, I would like to hear your motion against freeze all for all undergoing ART, please.
Thank you, and thank you for that kind introduction and for inviting me to speak today. It looks like I have my work cut out for me, and Dr. Jason has done a fantastic job convincing at least just over half of you. So hopefully I'll be able to convince you otherwise. None of my disclosures are relevant for this talk. And I want to start with saying that actually with most of what you presented, Jason, I have no absolute conflict with what you're saying. For high responders, OHSS risk, elevated progesterone, patients undergoing PGT cycles, or any patients undergoing ART where a pathology is being diagnosed, like thin endometrium, a uterine pathology like a polyp or hydrosalpinx, and obviously for fertility preservation, all these warrant a freeze-all approach. And as we can see in the graph, we know that PGT cycles have more than tripled over the last decade in the US alone. So obviously freeze-all cycles are increasing, as have we improved our ability to stimulate, culture, and freeze embryos. We do a lot more freeze cycles, but doesn't mean we can't do fresh cycles. So when I was given this debate topic and the motion to against freeze-all, I actually looked at why would we want to freeze-all. So as Dr. Fernandez mentioned very beautifully, the supraphysiologic hormones undoubtedly can have an impact on the endometrium. Can they also, by doing freeze-all, can we improve perinatal outcomes? It seems like possibly there's no loss in cumulative success, or is there? Flexible scheduling, reassuring child health data. Jason, I'm copying your presentation here. So I thought I'm in a bit of trouble here. So what do you do when you ask a question? You go to ChatGPT and ask, ChatGPT, should we do freeze all? And the answer is no, in short. So I tell myself ChatGPT can sometimes make up information and invent studies. So I'll go to something a bit more reliable. I go to open evidence. Open evidence, should we do a freeze-all? Again, no, we should not do a freeze-all. So I find myself in a situation where all AI is telling me we should not freeze-all. So it must be based on something. So I think I'll go to something more reliable. I'm going to ESHRE. And when I go to ESHRE, I look for a guideline saying, should we or should we not freeze-all? And you'd be surprised to hear there's no such guideline. But what you would find is an ESHRE ART center certification rule. So any center in Europe who wants to get an ESHRE certification, if they are doing a freeze-all cycle alone, only for all patients, they would be disqualified and would be declined certification. So that's pretty extreme. That's quite a stance on the side of ESHRE saying freeze-all is not good clinical practice. So why are they saying that? Because if you go back to basic science and you look at the supraphysiologic hormones that you see during stimulation, there's more than 200 genes that are dysregulated during the process of stimulation. We know adhesion molecules and genes, immune signaling, angiogenesis genes are all dysregulated during stimulation. We know there's complete altered cytokine network disturbance during stimulation. This will impact the whole maternal immune tolerance and obviously impacts the environment in which the embryo is implanting. So I go to my mentor, Professor David Gardner, who Dr. Fanasiak knows very well. And I asked him, David, I'm doing this debate and I'm supposed to present a motion against freeze-all, and I'm in a bit of a trouble, especially since David himself, Professor Gardner, published this study this year in Fertility Sterility, showing that alteration of endometrial environment has been well documented in animal studies. And that's why freeze-all strategy has been more and more employed over ovarian stimulation. And I asked him, Professor Gardner, my mentor, what do I do? I've got all these studies posing against me. He goes, sure, you know ovarian stimulation impacts the endometrium, but have you looked at the studies that show what freezing and thawing does to the embryo? Well, I went down that rabbit hole and I was blown away by the amount of studies looking at the negative impact of freezing, the cryoprotectants, and the thawing of the embryo. It starts with cellular activation and stress. There's upregulation of DNA damage repair, apoptosis, heat shock protein genes that are being presented during to the process. There's undoubtedly reduced cell viability. As clinicians, you all know when you do an embryo transfer, we know that not all cells survive the freezing and thawing process. There's a higher apoptosis compared to fresh embryos. We know there's oxidative and metabolic stress. This has been shown in multiple studies, osmotic shock and increased oxidative free radicals, disruption of mitochondrial function, inducing apoptosis. We know there's genetic and epigenetic alterations. There's a significant impact on impaired DNA integrity and disruption on imprinting polyprocessing genes expression. And we know there's a reduced developmental competence. If you look at embryos that have been frozen more than once, they've repeated vitrification associated with lower implantation, lower live birth rates. So undoubtedly, the freezing and thawing of an embryo has a significant impact. So we have to balance what is more important, the negative impact of the freezing and thawing, or the negative impact on the endometrium and that environment during stimulation. So I went to look at the largest RCT study. Obviously, you want to look at good studies, you go to New England. And I'm going to show quite a few New England studies in this talk. This is one of the largest RCT conducted today, although it's quite old, from 2018. It looked at the first transfer when you do a freeze-all versus a fresh transfer. But when only look at the first transfer, and this is back in 2018, so they looked at cleavage stage embryos, they saw no difference in live birth rate from the first transfer, whether they were transferred fresh or frozen. As you pointed out, Dr. Fanasiak, absolutely, OHSS risk would be higher in the fresh group, but this doesn't mean that we have to freeze for everyone. The rate of OHSS is 2%. We can definitely select these patients who are high risk And for them, definitely freeze-all can be beneficial. Unlike the study that you presented, Dr. Franaziak, about Christos Venitis, who presented a meta-analysis, this RCT did not show any difference in neonatal and obstetric outcome, and this is for over 2,000 women. And the conclusion from the study is individualization strategy, not universal adoption. So what do we do in an area where there's many RCTs? We go to Cochrane. And Jason has presented this Cochrane when he looked at OHSS. But what do we say about cumulative live birth rate? Obviously, the previous study that I've showed looked at the first embryo transfer. But at the end of the day, as clinicians, we want to know, are we losing pregnancies when we're incorporating a freeze-all strategy? The short answer, probably yes. But let's dive into the data. When we look at normal responders overall, if you look at cleavage stage, cumulative live birth rate, no difference between freeze-all and fresh. And also when we look at blastocyst, no difference between fresh and freeze-all in cumulative live birth rate. But let's dive a little bit into the major studies. First study looked at 1,500 women, cleavage stage, double embryo transfer. They looked at frozen versus fresh, showed a higher pregnancy at the fresh cycle. But what is really important to see, this is women with polycystic ovaries. Women with polycystic ovaries are high responders, high rates of premature progesterone rise, high rates of OHSS. Fresh transfer, to begin with, should not be incorporated in this subpopulation. Another thing they also observed, apart from the high rates of OHSS, is the fact that the cumulative live birth rate at 12 months was the same. So it's a matter of how you interpret the data and what group of population you're looking at. They also showed unsurprisingly, that from a fresh transfer, there was higher OHSS. In the frozen, high rates of preeclampsia, and I would agree. Back in those days, we used to do a lot of hormone replacement thaw cycles. We don't do that anymore because we know in the absence of a corpus luteum, the high rates of hypertensive disorders during pregnancy. The second important study shown in the New England, published that same year by a group from Vietnam, supported by my friend Ben Moll here from Australia. They also multi-center RCT, although much smaller than the previous one. They wanted to look at live birth rates, and they showed that there was no difference in live birth rates in women without polycystic ovaries when you compare frozen and fresh. And this is also supported by previous studies and also by subsequent studies. Remember, this is cleavage stage. We don't do as many cleavage stage embryos. I want to focus on the blastocyst embryo transfers because this is the current good practice. We do blastocyst embryo culture and blastocyst transfers. This is the first, although small, RCT looking at freeze-all versus fresh. And in all parameters, fresh did better than frozen. This is for a wider group of population, a study done in Netherlands. Some would argue this is a bit problematic. They did a day 6 blastocyst frozen embryo transfer. This is not always necessary if they're not slow growing embryos. But overall, what they've concluded from their RCT is that time to pregnancy was longer in the freeze-all, but in an unselected IVF population, lower cumulative pregnancy rates, longer time to pregnancy. Universal freeze-all is not recommended. This is probably one of the most important studies, I think, that were going against me. And when I looked at this study, I was quite concerned about presenting my motion because this was published at Lancet 2019. This is a huge study, 21 Chinese fertility centers, multi-center RCT, 1,650 women undergoing their first IVF cycle. And what they saw is frozen embryo transfer. We're talking about only the first transfer, 50% frozen versus 40% live birth rate from fresh. Undoubtedly very good high pregnancy rates, no different in OHSS, no difference in pregnancy loss, higher preeclampsia as expected in the frozen group. Neonatal outcomes quite similar overall, apart from slight birth weight in the frozen group. But what they showed is that a frozen single blastocyst has higher pregnancy rates compared to a fresh when you do the first transfer, then I'm in a bit of a problem. This is a Lancet study, RCT, very good conducted study. Or is it a very good conducted study? Well, when you look into the study and you start reading it, you start seeing some problems. First and foremost, this is a very specific subpopulation between 20 and 35. I wish all my patients in my IVF clinic were between 20 and 35. What we know nowadays is actually about 30 to 40% of our patients are over 40. And the remaining quite significant portion is over 35. And they obviously excluded many patients. They excluded over 1,000 women, but most concerningly, 2/3 of the women excluded were because they did not have above 4 good quality embryos on day 3. So this study excluded all patients who had less than 4 good quality embryos. I wish we all had such good prognosis patients, but that's not reality. That's not really the case. And they got a lot of criticism after this study was published. There was some deviations and performance bias. For example, they had more than double the amount of patients going through a double embryo transfer in the frozen group compared to the fresh. That would cause quite a significant bias. But they got a lot of scrutiny after this study. So this study was done by Damien Way. I don't know if he's joining into this conversation, but the same Damien Way published another study only a couple of years later. What Damien did is basically looked into 337,000 cycles. I don't know many studies that looked at real world data on such a huge number of cycles. And they wanted to see what the cumulative live birth rate was for freeze-all. And what they saw is that there was 20% less pregnancies. This is a huge study, huge, 337,000 cycles. So they said that this is mostly due to the embryonic loss from freezing and thawing. And they concluded that freeze-all may benefit some, but universal risk for lower cumulative does exist. This same Damien Way published another study this year, and this is where he dropped the mic. This is probably the most important RCT in the context of freeze-all versus fresh. And what they did in this study, they took women with low prognosis, meaning less than 9 eggs collected. And they did an RCT comparing fresh and frozen. And this basically blew us away. This was published in the BMJ earlier this year, and they showed higher live birth rate, higher clinical pregnancy, higher cumulative live birth rate in the fresh transfer compared to a freeze-all strategy. What also they saw is that in the freeze-all strategy, there were higher miscarriage rates. And this is a landmark study by the same group who published the study suggesting that freeze-all is beneficial after checking just for the first transfer. So they looked at multi-center, they looked at cumulative live birth rate, they basically corrected all the errors they did in studying 2019. And they looked at the subpopulation, which we all struggle, which is the population that is a poor prognosis. And for them, freeze-all is going to be detrimental. So I'm not going to argue about obstetric risks. I can have some statements about Christos Venitis' study that he published, his meta-analysis, which was very important to showcase some of the risks associated with fresh versus frozen. We also not just need to look at the risks, we need to look at the absolute risk. How many cases are we increasing versus how many pregnancies are we increasing? So theoretically, you might be increasing complications, but you are increasing the number of pregnancies. And at the end of the day, we as gynecologists and obstetricians, we can learn how to navigate these risks. We can reduce these risks by closer monitoring. We can reduce this risk by aspirin. There are many ways of incorporating better perinatal outcomes. But to improve live birth rate, that is something that only as fertility doctors and scientists, we have the tools to do. And by doing a freeze-all strategy, we'll be having less babies. There's encouraging data in terms of pediatric growth and development and epigenetics. Overall, data from fresh versus frozen are very, very reassuring. And although the HFEA has said that there's a slight increased risk in Beckwith-Wiedemann from frozen embryo transfers. I would not put that against the motion of freeze-all. I don't think that is the reason we should do a freeze-all or fresh. The reason we should do a fresh in selected cases and freeze-all in selected cases is the higher pregnancy rates. And in terms of complications, we need to know how to manage the risks and personalize the treatment. In terms of cost effectiveness, I think it's really important to say that it depends which country you're practicing. This study was published based on the Vietnamese study costs, and it showed that freeze-all strategy ended up being 600 euros more expensive for every live birth. But obviously in the States, that would be a lot more expensive. And in some countries where this treatment is more expensive, the difference may become bigger. So in summary, selective freeze-all has a clear indication, and I would not argue. OHSS risk, elevated progesterone, PGT, pelvic or endometrial pathology all require our attention and all require freeze-all. But in reality, these are not the majority of our cycles. The majority of our cycles may also this can be very detrimental too. By doing a universal freeze-all, we have no gain or possibly lower cumulative live birth, delay time to pregnancy, there's increased maternal risk for some conditions, higher cost, extra appointments, emotional burden, but most importantly, lower pregnancy rates and poor responders. So personalized, not protocolized approach. Thank you.
All right. Thank you very much, Dr. Landsberg. Very insightful information. So right now, I think all the audience have more data, okay, to consider whether to go freeze-all or selective freezing. Okay, so well, I will give 5 minutes for each of you for rebuttal. Okay, and we can have the poll again after you both give rebuttal. So let me ask Dr. Fernandez to spend 5 minutes for your rebuttal, please.
Thank you very much. And thank you, Dr. Landsberg, for that really very inspiring talk. A great review of the literature and very good data presented. I don't know that I'm going to take a full 5 minutes to rebut all of the things that were noted. I will say that I do feel a little behind the 8 ball in the debate. Whenever you have an absolute statement, there's always exceptions to that statement. So I feel pretty solid that I started with a very slight majority. We'll see how it looks after it's all said and done here. A couple of things that I will say, you know, many of the studies, some of the early studies presented with fresh versus frozen, as Dr. Landsberg acknowledged, were with embryologic and clinical practices that we don't use very much any longer. Many of them were cleavage stage embryos. And if you looked at the actual pregnancy rates in those studies, I think many of us would be a little embarrassed to have clinics that had pregnancy rates that were that low. So I think that that's an important thing to consider. Even from those studies, there may have been improvements in the clinical and embryologic care. I do think one of the important components for the freeze-all approach is the concept of trying to build an entire family and not just the first pregnancy with a single ovarian stimulation cycle. The ovarian stimulation cycle is the one where the majority of the risks take place, and having to have patients do multiple fresh cycles could increase those risks for patients. Doing a slightly more aggressive ovarian stimulation, not having to worry about late onset OHSS with a fresh transfer, would allow for clinicians to retrieve likely more oocytes in a single IVF cycle. I think that the data is pretty clear that us in the United States are much of the world might even consider cowboys in terms of our stimulation of the ovaries. So we're fairly aggressive in the United States with our ovarian stimulation in an effort to try to get enough embryos for not only the first pregnancy, but for the entire family. I do think one of the other challenges is that you really are doing a balance between trying to treat an individual patient and treat a group of patients. Assuredly, there are aspects of cost, and that additional cycle of a frozen transfer can incur additional costs. I do think whenever a cost study is looked at, it needs to also take into account perhaps some of the other untoward impacts of a fresh transfer in terms of the late onset OHSS and perhaps some of the other neonatal outcomes. Although, as Dr. Landsberg presented, there are some studies which have not shown differences in neonatal outcomes. So I will conclude by saying that for a freeze-all approach, it would allow for more aggressive ovarian stimulation in an attempt to build an entire family with a single fresh cycle. There are a number of studies which have shown improved outcomes, particularly in patients that have premature progesterone rises, as Dr. Landsberg did agree with. One of the other aspects that I do think about is the embryology, and that is sometimes something that the clinicians don't see as much. That kind of veil between the clinical side and the embryology lab is not always transparent, and we don't have the ability to always see whether or not embryos are synchronous with the endometrium. So with that, I will conclude, and I'll let Dr. Landsberg rebut as well.
All right, thank you so much. So I will give 5 more minutes to Dr. Landsberg to win back your poll. So you have 5 minutes to rebut on your stand, and then after this, we can have a final poll before we close.
All right. Thank you, Dr. Fanasiak. You are a worthy opponent of this debate, and you make very important and valid claims. Some of them I actually truly support. I do think that for high responders, patients who can respond with a high number of eggs for the purpose of family planning, freeze-all approach is beneficial. But actually, this work was done for me. And there's a beautiful study looking at 82,000 cycles. And they divided the pregnancy rates and miscarriage rates and birth weight based on number of eggs retrieved. And undoubtedly, if you look at these graphs, the blue represents fresh, the red represents frozen, and this is 1 to 5 eggs, 6 to 14 eggs, and above 15 eggs. If you look at clinical pregnancies and live birth rates, undoubtedly doing a fresh transfer would have a higher, both in 1 to 5 and 6 to 14 eggs, higher pregnancy and higher live birth rates compared to frozen. When we look at above 15 eggs retrieved, this is where the graph changes and the favor goes towards doing a freeze-all. And this also supports my approach. High responders, OHSS risk, and also goes along with your statement. Family goals, doing more aggressive stimulation, you can get better results. This is also true for miscarriages. Lower miscarriages, when you get lower number of eggs and incorporate a fresh transfer compared to a frozen transfer. And this relates not just to the endometrium. You have to remember, freezing and thawing an embryo is not a benign intervention. It is an extremely stressful event for the blastocyst. And we have to take that into consideration when considering a freeze-all versus fresh. It's not only about the endometrium. So one more slide that I wanted to show, and that slide, I think, helped me reinforce my position against freeze-all. And this is a study performed by a good friend of mine, Professor Christophe Bloquiel from Brussels IVF. Christophe conducted a survey among fertility specialists around the world. This is called the Delphi Consensus. And on statement number 4, Christophe sent a question to all fertility specialists asking, when initiating ovarian stimulation, when would you prefer a fresh transfer? And 94% agreed for poor responders, do a fresh transfer. 92.3% agreed, normal responders, fresh transfer. High response profile or risk for HSS, the decision or the answer was split in half. 50 were more for fresh, 50 were more against. And I would be more conservative than they, and I would even join Dr. Franazic in saying high responders, freeze all. Definitely if you identify risk for hyperstimulation or premature progesterone rise. And lastly, in that same study, Professor Blakil asked the same specialist, when would you consider doing a freeze-all? And there's no argument. Risk for hyperstimulation, 100%. Inadequate endometrium, 100%. New pathology in the cavity like a polyp, 100%. Premature progesterone rise, 98%. New diagnosis of tubal pathology like hydrosalpinx, 98%. There is no argument. We have room for freeze-all. There's no argument about that. But incorporating a freeze-all to everyone uniformly without looking at the specific circumstances is exactly doing the opposite of what we're trying to achieve through modern IVF, which is personalize the intervention, personalize the treatment.
All right. Okay, thank you so much, Dr. Landsberg. Okay, before we go to the final poll, let me lead you to a few questions that we get from the audience, because topics today is very interesting, and these are the scenarios that we as fertility doctors are facing every day when patients comes and ask. Many times it is not only science, it is more like scenario based as well. Okay, so well, before we go to our final poll, let me read out the questions that we have from the audience, and we're gonna help answer this question. The first one: why is OHSS reduced in freeze-all cycles? At the point of egg collection, surely the risk OHSS risk is the same. Okay, I would.
So when incorporating a freeze-all cycle, assuming we are doing an antagonist cycle or progesterone prime cycle, and there's no reason to suspect hypogonadotrophic hypogonadism, meaning the patient is likely to respond to a GnRH agonist trigger. It has been shown in multiple studies, very large well-conducted studies, that the risk of OHSS has significantly been reduced for early and also late as a result of the fact that we're not doing an embryo transfer. The reason we don't do an embryo transfer after a GnRH agonist, both for reduction of OHSS and also studies that have shown lower live birth rates and lower pregnancies after a GnRH agonist trigger. So OHSS risks has widely been shown in an antagonist cycle or progesterone prime cycle to be almost eliminated. There are case reports of OHSS after a GnRH agonist, but those are extremely rare.
All right, thank you so much. The risk is significantly reduced with the use of GnRH agonist trigger, which is one that we can do for the freeze-all. So, well, the next question, probably it should be good with Dr. Franazic. For freeze-all cycle is equivalent to 2 cycles procedures. What is the added cost? Should frozen live birth rate be reported differently from fresh embryo transfer cycle?
Yeah, so I think that additionally, as the individual pointed out, there are certainly additional costs, and Dr. Landsberg had also presented that. I think it is very astute to note that it depends upon where the care is being performed, how much that cost difference might be. I also do think that there are some other things that need to be taken into account when cost studies or cost analysis are done. There are some additional untoward impact of doing fresh cycles, and I think those need to be taken into account when you're looking at cost differences between the two. In terms of live birth, I think that it should be reported as the cycle was done. The live birth should be reported as a fresh or a frozen transfer. I don't know that it has to be reported any differently otherwise. But I do think that there is always the concern of added costs. One of the largest things that we think about is if there's a difference in pregnancy outcome, there's added cost to doing a subsequent cycle after a failed transfer.
All right, thank you so much. So for the next three questions, I will bundle up because it is all three has involved the neonatal outcome. Basically, the question is with the increased risk of big babies from frozen cycles over fresh cycle, what are the chance of having, I mean, there's the statistic difference between showing that you had more of a live birth with from frozen cycles, but is that have any clinical significance?
I think that is the question with respect to neonatal outcomes. What is the clinical significance of this? First, we have to acknowledge that some of these studies are mostly meta-analyses, and as we all know, meta-analyses, only the one conducting them knows what goes in and what comes out. The question is, for example, the Christos study that you did, which is a very good conducted study, but also included cleavage stage embryos, blastocysts. It included time where we did vitrification, we included slow freezing. There is so much mixture of information, and best results can be withdrawn from RCTs. And large RCTs, most of them show no significant difference, mostly because they're not powered to show significant difference if there's a few more cases of a specific obstetric complication. And in order to power and do all the confounding factors, because we know all obstetric complications have so many different risk factors, apart from whether they were just doing fresh or frozen embryo transfer. So to make conclusions based on the type of embryo, whether it was fresh or frozen, is very, very difficult. There is consistent to see that babies born from a fresh embryo have slightly to be smaller and born earlier compared to frozen that have a tendency to be slightly bigger, and high rates of cesarean sections as a result, possibly. Most of these obstetric factors, I think, don't have a huge clinical significance in the context of decision, because the absolute risk is still considered low. The management, most of the time, unless, of course, we're talking about severe prematurity or very significant IUGR, unless we're talking about such severe complications, most of these obstetrical complications are manageable. They could be risk reduction strategies. And I don't think any of us would stop transferring frozen embryos because of these statements of the complications from frozen embryos. We are looking at pregnancy complications, but we also have to focus on pregnancy rates and live birth rates. And we know that in general, many of our interventions can cause implications down the track on the pregnancy, on the neonatal and obstetric outcome. But unless overall we see a significant trend towards impact, I think we should focus on the strategy of trying to achieve more live births.
All right, thank you so much. So I think we are about to run out of time. So Shishi, can we pull up the final poll before I gonna, all right, so we're gonna pull up for the final poll. Okay. And well, please let us know when we get the result. And after that, I will ask Dr. Patil to conclude today before we close.
I want to take the opportunity while everybody's answering the poll to thank the organizers for this very fascinating, interesting debate, and Dr. Jason Fernasiak for waking up so early in the morning in the US. And we cannot even say that the sun hasn't even risen where you are, I would imagine, or just rising as we speak. So thank you for making, just coming up. So thank you for making that amazing effort and being so sharp even at this early time of day for you.
It was a lot of fun to talk, and It looks as though you have assuredly persuaded folks against the freeze-all for everybody.
I thank both the speakers, Dr. Jason as well as Daniel, for this fantastic debate. And both have given their insights for and against the motion whether we should freeze for all. And I think it should be an individualized strategy. It is definitely indicated when there's risk of OHSS or one is going for PGT, fertility preservation, or when there's a progesterone rise. And also when we are using the alternative protocols like the random start protocol as well as the PPOS. But otherwise, also if you look at one of the meta-analysis which was published by Matthew Rogue, where he said that definitely there was increase in the live birth rate, but then when he did the subgroup analysis, it showed that it was advantageous only in those patients who were high responders or who had PCOS, but not in the normal responders as well as those who were poor responders. Plus, we really do not have many studies who have looked at the cumulative pregnancy rates either with freeze-all or with fresh transfers. And I think in future, when we have these studies, it would definitely make a difference. So I thank you all again on behalf of Aspire for being with us for this wonderful webinar.